Welcome to This Explainer. Today, we're diving straight into the American Heart Association's blueprint for tackling acute hypertensive crises right in the emergency department. Look, hypertensive crises make up a massive chunk of ED visits every single day. But honestly, mismanagement is still one of the top sources of preventable issues. Getting this right is absolutely critical for your patients. So, let's get into it.
All right, picture this. You're on a crazy busy shift. The board is completely full, and the 58-year-old guy hits the triage bed. He is totally asymptomatic. He's talking, he's comfortable, but then the nurse hands you a slip of paper, and his blood pressure is a staggering 240/130. We've all been there, right? There's this immense psychological pressure when you see a number that high. The alarms are dinging, the staff is staring at you, and the tension in the room just instantly spikes. So what's your gut reaction? The natural clinical instinct in that moment is to just panic a little. You want to push IV meds, drop that number instantly, and just make those alarms stop. Historically, that's exactly what a lot of us were taught to do. But should you really be treating the machine? According to the AHA, we actually need to hit pause, take a deep breath, and totally rethink our approach to these high-pressure scenarios.
Here is our roadmap for today. We'll start with the hypertensive myth, move on to spotting target organ damage, and cover the essential workup. Then, we'll hit BP reduction principles, disease-specific pathways, and finally wrap up with a practical ED algorithm.
Okay, part 1, the hypertensive myth. Let's tackle this ED pitfall head on.
So here's the massive paradigm shift we need to make. Take a look at this side by side. On the left, we've got hypertensive urgency, that's severely elevated blood pressure, but, and this is key, absolutely no acute organ damage. Now, on the right, we have a true hypertensive emergency. That is severely elevated blood pressure paired with acute target organ damage. Conflating these two is incredibly dangerous. If you aggressively treat urgency like an emergency, you can actually cause strokes and heart attacks. The bottom line, the numbers alone never define an emergency. The actual presence of acute target organ damage does.
Moving right along to Section 2, spotting target organ damage.
Since that target organ damage is a real enemy, how do we spot it quickly? Well, you've got to be super systematic. You need to check these 6 critical systems through a highly focused history and physical. You're hunting for specific red flags. For the brain, any subtle or sudden new neurologic deficits. For the heart, you're ruling out chest pain or ischemia. The aorta, you're not just asking about regular back pain, you want to know about that severe tearing sensation radiating to the shoulder blades. Check the kidneys for hematuria or a sudden drop in urine output. Look at the eyes for acute changes like papilledema. And of course, in pregnancy, you're watching like a hawk for eclampsia. Your exam has to be laser-focused on finding out if any of these specific systems are under attack.
All right, Section 3, the essential workup.
Okay, so let's say you suspect organ damage. Now it's time to get the diagnostic data to prove it. Notice how tightly this workup maps to the organ systems we just talked about. According to the AHA, you should order these specific tests to confirm exactly which organ is failing. We have to completely ditch the shotgun approach where we just order every test under the sun for every hypertensive patient. You grab an ECG and troponin only if you suspect cardiac ischemia. You get a CT brain or CTA if you're worried about a stroke or a bleed. A BMP, creatinine, and urinalysis to confirm acute kidney injury. And a chest x-ray for pulmonary edema. Every single test you order needs a distinct, justifiable purpose.
Which brings us to Section 4, BP reduction principles. This is the absolute core of the explainer. If you actually need to intervene, here is the golden rule. You generally reduce the mean arterial pressure by no more than 20 to 25% in the first hour. This is absolutely vital to avoid devastating complications. Just think about the physiology for a second. In a chronically hypertensive patient, their body has adapted. It actually relies on that high pressure to push blood into the brain and the heart. If you drop that pressure too fast, you literally pull the rug out from under them. You risk starving the brain and heart of vital blood flow, which could inadvertently cause an ischemic stroke or an MI right there in your ED. Precision and patience are everything here.
Now, how do we actually do it? You can't just grab whatever antihypertensive is closest in the med cabinet. You need the right pharmacological tool for the job based on its mechanism and onset. Nicardipine is a calcium channel blocker that works in minutes and is super titratable, perfect for neuro or renal cases. Labetalol, an alpha and beta blocker, is your absolute go-to for aortic dissection or pregnancy-induced crises because it stops reflex tachycardia. And nitroglycerin, that's a rapid-acting vasodilator that's fantastic for acute heart failure and flash pulmonary edema because it reduces preload so well. Choosing the right drug makes all the difference.
Okay, Section 5, Disease-Specific Pathways.
This is where it gets really interesting, because treatment goals are widely different depending on the specific pathology you're dealing with. For an aortic dissection, you've got a mechanical tearing of a vessel wall. You need to drop that systolic pressure below 120 rapidly, usually within 20 minutes, using something like esmolol or nicardipine to reduce the shearing forces. But contrast that with an acute ischemic stroke. In that scenario, you actually allow permissive hypertension. You might literally let their systolic ride well over 200 just to maintain collateral grain perfusion and keep that ischemic penumbra alive, assuming you aren't giving TPA. And for pulmonary edema, nitroglycerin takes the lead. The guideline emphasizes that your treatment is entirely dictated by the disease, not just the number on the screen.
Finally, Section 6, the practical ED algorithm. Let's tie it all together.
To simplify the chaos on your next shift, just follow these steps methodically. Step 1. Always repeat the blood pressure correctly. Make sure the patient is calm and you're using the right cuff size before you do anything. Step 2. Do that highly focused exam for those 6 systems we talked about. Step 3. Ask yourself, is there active target organ damage? If the answer is no, move to Step 4, observe them, maybe give an oral med, and manage them safely as an outpatient. But if the answer is yes, you go to Step 5, initiate immediate, targeted IV therapy, and admit them. Confirm the numbers, hunt for the damage, and only start IV drips if the organs are truly under attack. As we wrap up, I want you to be on high alert for these common ED pitfalls. Do not fall into the trap of dropping the blood pressure too fast and accidentally causing ischemia. Seriously, avoid treating the numbers instead of the actual human being in front of you. Don't use the wrong medication for the disease state. Remember, heart failure needs a totally different approach than a dissection. And finally, never rush a discharge without reassessing or brush off subtle signs of organ damage. Sticking to the AHA guidelines helps you dodge these traps completely.
Okay, if you literally only take one single clinical pearl away from this entire explainer, please let it be this HHA-backed philosophy. Treat the target organ damage, not the number. It's a huge, fundamental shift away from panicking over digits on a screen and towards meticulous, patient-centered care.
So I'll leave you with this final thought to challenge your practice. The next time you walk into a bay, the alarms are screaming, and that monitor reads 220 over 120, are you going to treat the machine or are you going to treat the patient?